interest of time. So welcome everybody. Welcome to, what month is it? It's February. Welcome to the February version of the JVS Online Journal Club. Happy day after Valentine's Day for those of you who celebrated. We did try not to have this on Valentine's Day, contrary to my request, but we'll go ahead and introduce our host institutions. Let me share my screen. So there we go. All right. Tonight we have two papers which we're excited to be talking about, both from the contemporary JVS. Endovascular aneurysm repair offers a survival advantage and is cost effective compared with conservative management in patients physiologically unfit for open repair. The authors for this paper couldn't be here today, so we'll have a great time chatting a little bit about it. But then, of course, the clinical presentation, operative management, and long-term outcomes of rupture after previous abdominal aortic aneurysm repair. And we're lucky to have Dr. Sen, Dr. Rasmussen, and she goes by Dr. Irina, who are all here to talk about their paper and to help us explore their results. SUNY Upstate and MedStar Health are our hosts this evening. We'd like to thank Dr. Paul Mashah, who is the faculty host, sorry about that, and then Dr. Dina Shade, who is a second-year vascular fellow from MedStar Washington Hospital, Dr. Crystal Maloney, and their fourth-year integrated resident, Dr. Caitlin Dunphy. Sorry, I left out the T. We have the authors again from the paper regarding ruptured aneurysms and previous repairs. All of them will be here to kind of explain their results, Dr. Rasmussen and Dr. Sen, and then Dr. Arena, and our two editorial board guests who we're thrilled to have. So Dr. Nick Mawad, who is the Chief of Vascular and Endovascular Surgery. He is Vice Chair of the Department of Surgery and Chief of Staff at McLaren Health System in the Bay Region. And then Dr. Linda Harris, who is a Professor of Surgery and Program Director for the Vascular Residency and Fellowship at the University of Buffalo. So just a few things to keep in mind. We will ask you to stay muted, but please put your questions and comments in the chat. Our moderators will feed those to the authors, or we'll talk about the second paper where the authors aren't here, and we can kind of discuss some of the nuances of that. The event is being recorded for on-demand access. And then in March, we'll be having the JVS Online Journal Club March 9th at 7 p.m. Central Time. So I'll stop sharing there and we can move forward.
All right. Good evening, everybody. Thank you for the opportunity to present. I am Crystal.
Can you swap the display real quick?
Oh, yeah, sure.
Perfect. Thank you.
Okay, better. Thank you. I'm Crystal Maloney. I'm coming to you from MedStar in Washington, D.C., and I'll be presenting the first paper. So, sorry. I started with the wrong presentation, of course. Yeah. Okay, so abdominal aortic aneurysm repair, there's basically two modes of treatment that are used for infrarenal repair. There's an open repair and an EVAR. In the 1950s, the open repair became popularized mostly due to the advent of the Dacron graft by Dr. DeBakey. Prior to that, there was no great way to really repair these aneurysms. Cadaver grafts were used, aneurysmorrhaphy was used. But it wasn't really until the Dacron graft was introduced that this took off and became widely popularized and used. This was the most common method of repair until about the 1990s when Juan Perotti introduced the EVAR device. This did take some time to become popularized and become widely adopted, but in modern day, it has really taken off. Here's a look at trends in open versus EVAR for elective abdominal aortic aneurysm repair. This is a paper that was published in 2018 and looks at trends from 2003 to 2013. And you can see the crossover around 2005. Prior to this, it was more common to do an elective open repair. And after, it was more common to do an EVAR. Here's another data set from a more recently published paper that looks at more modern data. This was published in JAMA in 2022. And again, this was looking at Medicare beneficiaries. The groups are grouped into 5-year intervals. And in 2003 to 2008, EVAR versus open was more or less equivalent. You can see that there's a rise in popularity in EVAR over the next 5 years, and then it grows quite exponentially. In addition to this, you can also see that we're doing a lot more abdominal aortic aneurysm repairs. So the main question is, what is more durable? And that gives you some insight to my battery bias. So how this can fail. For an open repair, you can get peranastomotic or anastomotic aneurysms. They occur slowly over time. The peranastomotic aneurysm is due to a degeneration of the aorta above or below the graft. An anastomotic aneurysm is usually a pseudoaneurysm, and it can be due to infection or just a breakdown of the suture line at the suture line. Again, these occur slowly over long time intervals, hence the SVS guidelines for surveillance are at first 1 and then 5 years. The rupture after an open repair is about 1 to 6% by varying studies. For an EVAR, the rupture rate after an EVAR is 7 to 15%. So it's much more often, and there's much more that can go wrong. So I'll go over endo leaks briefly. A type 1 endo leak is due to failure of the proximal or distal fixation. Type 1A is from proximal, B is from distal. And this can be due to calcification, thrombus, a change in the aneurysm sac conformation that loses the seal. These don't resolve on their own. They need to be fixed. A type 2 endoleak can be due to back bleeding from lumbars or the IMA. If there's no growth in the aneurysm sac, they don't need to be repaired. But if there is growth, it can lead to a type 1 or a type 3, therefore need to be fixed. A type 3 is from a separation of the components of the graft. Like a type 1, this doesn't resolve on its own and needs to be fixed. A type 2 is due to porosity or bleeding from the interstices of the graft. It's typically seen in the OR when the patient's heparinized and resolves thereafter. And a type 5 is called endotension. It's something that's not well understood, but it's an adverse pressurization of the sac in the absence of an endoleak. With the advent of the fenestrated grafts, it becomes a little bit more complicated. There's a few more possibilities for failure. There's a 1C, which is a side branch attachment, back bleeding, and a 3C, which is from a break in the side branch. So what does this mean? We're doing more and more abdominal aortic aneurysms over time, and we all know that they're at risk for failing, EVAR more than open. And what we're going to see is probably an increase in the ruptures after elective repair. So this paper looked at the clinical presentation, operative management, and long-term outcomes after rupture for previous abdominal aortic aneurysms. And with that, to go through the paper, I'll turn it over to Caitlin Dunphy.
All right, thanks, Dr. Maloney. I'm just going to start sharing my screen. Sorry, 1 second. We did this last night and there was a little bit of an issue. Sorry, 1 second. I'm so sorry.
No problem. Take your time.
All right, I think I just have to share my actual desktop. I don't know whether it's not recognizing my PowerPoint. I'm not sure why.
That should work too, and we can let you know if we can't see it well.
All right. here. Okay, and then let's try this. All right. Oh, looks like we are good. I
Just
don't know if I
swap
can-
your displays where it says swap display up there and it'll flip it.
Oh, right there. There we go.
And then we can see the name. Beautiful.
Okay, great. All right. Good evening, everyone. Thank you to Dr. Maloney for your introduction, and thank you to the Journal Club for the opportunity to present today. I will be discussing the article entitled Clinical Presentation, Operative Management, and Long-Term Outcomes of Rupture After Previous Abdominal Aortic Aneurysm Repair. And thank you to Drs. Sen and Rasmussen for joining us. Late aortic rupture is thought to occur in about 1 to 3% of patients after AAA repair, whether treated endovascularly or with open repair. Prior studies have noted that fewer than 20% of ruptures are due to failed endovascular interventions. However, there has been an increase in delayed open conversion after EVAR, and there is little data regarding late aortic repair after open repair as the index procedure. Late aortic repair after EVAR is likely secondary to implantation of EVAR off of the instructions for use. EVAR used to treat initial rupture, persistent endoleaks, and loss to follow-up. Overall, these patients are challenging to manage as they can present with hemodynamic instability with complex anatomy that may or may not allow for treatment with conventional methods. When patients have required a delayed open conversion in the setting of rupture, the perioperative mortality risk is up to 55%. The main purpose of this study was to evaluate a single center experience with late aortic rupture and to evaluate potential risk factors as well as survival trends. In addition, outcomes between patients treated with open repair as well as endovascular repair were evaluated. The primary endpoints for this study were 30-day mortality, major adverse events, and overall survival. The study was performed at a large tertiary referral center, and all patients from 2000 to 2020 who presented with infrarenal aortic rupture after prior repair were evaluated. Data was obtained, including demographics, details of their index and subsequent repairs, as well as survival data. Patients were excluded if they had complex aneurysm, a thoracoabdominal or paravisceral aneurysm, an aortic enteric fistula, graft infection, or graft limb thrombosis. Outcomes of patients who were treated with both open and endovascular repair were compared. Surveillance was initiated in accordance with current SVS guidelines. Therefore, patients treated with endovascular repair had serial CTAs performed at 1, 3, 6, and 12 months post-procedure, and then subsequent yearly ultrasounds. And patients treated with open repair had a CTA at 1 year and then once every 5 years. Statistical analysis was a p-value was less than 0.05 was used to define statistical significance, and regression analysis was used to assess 30-day mortality and major adverse events. This figure shows how the final study group was obtained. While there were 5,861 patients who were assessed for eligibility in the study range, only 40 met criteria. Patients were excluded if their aneurysm was not infrarenal or if it was a primary rupture in addition to other exclusion criteria mentioned prior. Patients were then placed into two groups. Group 1 is patients whose secondary rupture was treated endovascularly, and group 2 patients were treated with open repair. The demographic characteristics between groups 1 and 2 were obtained. There were no significant differences between the two groups with the exception of cigarette use and BMI. Patients in group 2 were more likely to be active smokers, whereas patients in group 1 were more likely to be previous smokers. Patients who were treated in group 2 also had a higher mean BMI of 30 compared to group 1, which mean BMI was 28. Intraoperative details were also obtained, and those treated with open repair had a higher mean EBL of 3 liters plus or minus 1,500 versus 600 plus or minus 1,000 for endovascular management. So the study followed 40 total patients, 30 of whom had an index procedure of EVAR and 10 of whom had an index open repair. The cause of late aortic rupture was endoleak in all of the EVAR patients, 19 of which were known prior to presenting with the late aortic rupture. So of those 19 that were known endoleaks, 9 of those had a type 1 or type 3, whereas 10 had a type 2. And 7 of those patients that had a type 2 had undergone prior interventions, whether it was IMA or lumbar embolization. And then patients who presented with late aortic rupture after open repair were usually secondary to ruptured periagnostic pseudoaneurysms, 8 of which were proximal and 2 of which were distal. So follow-up was noted to be poor overall for patients who presented with late aortic rupture. 22 patients had incomplete follow-up, and 8 of those were completely lost to follow-up. The time to late aortic rupture was shorter in patients who had an index EVAR compared to open repair, and this was statistically significant. For EVAR, it was 6 plus or minus 4 years, whereas for open, it was 12 plus or minus 4 years with a p-value of 0.003. So overall, the 40 patients evaluated in the study, 25 were repaired with EVAR, whereas 15 were repaired open. The endovascular group was treated with fenestrated repair, EVAR, cuff, limb extension, or a hybrid repair with an AUI and a fem-fem bypass. And 8 of these patients were endovascular salvage from a prior open repair. Whereas on the other hand, there were 15 patients who were treated with open repair, and 13 of those were a delayed open conversion from a prior endovascular repair. This explains some of the high clamp sites needed for graft explant. Throughout the study, it was noted that there was significant crossover between groups, and more patients with previous open repair were treated with endovascular salvage. This figure represents 2 major findings. First, that there were significantly more AAAs treated after 2009, and second, that late aortic rupture was more frequent in the second half of the study, so after 2009. So in comparing group 1 versus group 2, there were no statistically significant differences in early mortality. However, 42% of patients experienced a major adverse event, and this was defined as an AKI with a GFR change greater than 50%, a new need for hemodialysis, MI, respiratory failure, paraplegia, stroke, or bowel ischemia requiring resection. The only statistically significant difference was that the group 1 had less blood loss and less need for new hemodialysis. And there was no difference in the length of stay or disposition post-hospitalization, and multivariate analysis and linear regression did not identify any risk factors associated with 30-day mortality or major adverse events. For both groups, the median follow-up was 21 months with a range of 6 to 45 months. The top figure notes the percentage survival at each follow-up interval. There was no difference in survival between groups at each interval or overall. And additionally, there was no aortic deaths except for the ones that were early. So there was 2 of those total. The bottom figure demonstrates reintervention-free survival, and there is significant difference between groups as the endovascular repair required reintervention in 3 patients, all of which had a type 1 endoleak. Overall, the incidence of late aortic rupture is increasing as late aortic rupture after EVAR. This is likely secondary to an increased number of EVARs being performed. A VQI study of almost 13,000 patients noted a 5-year late aortic rupture rate of 3% post-EVAR, and a Medicare database review noted a significant difference in late aortic rupture at 8 years for EVAR compared to open repair. Late aortic rupture post-EVAR can occur secondary to endoleak, which can subsequently lead to sac pressurization and rupture if not identified and treated. And furthermore, late aortic rupture that is treated with EVAR has a lower reintervention-free survival. This mirrors the outcomes seen with EVAR as an index procedure, in that endovascular repair has a higher frequency of subsequent interventions and therefore requires strict postoperative surveillance. In conclusion, up to 10% of patients who present with a AAA rupture at a tertiary referral center have undergone a previous aortic operation. These patients can be safely treated with endovascular or open repair with no significant difference in early mortality. Takeaways for changes in clinical practice include a need for appropriate surveillance of endovascular repair. While many of these patients are scheduled for follow-up, there are multiple patient and physician factors that can influence appropriate follow-up. Further research into organized insurance or hospital-linked follow-up reminders is likely needed. Additionally, late aortic rupture is more common now that endovascular repair is widespread. Many of these patients have late ruptures due to poor adherence, they're thought to be due to poor adherence to the instructions for use. Therefore, physicians who perform these procedures should carefully consider the anatomic and physical constraints when choosing the correct AAA repair technique. Finally, late aortic rupture can be safely managed endovascularly regardless of the technique used for the index repair. Thank you.
Thank you very much, Dr. Dunphy, Dr. Maloney, and appreciate the opportunity to be here as part of the Journal Club, please send your questions to the chat, but I'm just going to get this going. Very impressive study. Obviously, single institution, over 5,800 aneurysms repaired. But when we see this, that around 10% of those that were repaired ended up having a late aortic rupture. And as you guys had divided into 3/4 EVAR, clearly because of an increasing EVAR towards the later part of that period, and 25% open repair. So just to start off, I know there's always been a controversy with endovascular reconstruction versus open reconstruction, and I was very impressed to see in the study. Do you think that we need to be more aggressive, as you mentioned in your paper, after initial EVAR aneurysm sac expansion, those with an endoleak type 1 or type 3 or an absence of aneurysm sac shrinkage was detected in all patients that had a late aortic rupture, which has been a topic of conversation. So do you believe in EVAR surveillance, the lack of aneurysm shrinkage should promote a further intervention? Do we feel that the aneurysm in and of itself has not been repaired, as you guys have demonstrated?
I think, yeah, for sure, that's a very valid pathway. And I think we could show in this study that overall, it is the larger aneurysms which rupture. So, and in this small subset, everybody who had an EVAR failure and ruptured, we could sort of see that it was growing, boom. And, more interventions still not responding to the size criteria. So we always do talk about, size being not just it, but I think at some point we have to say that, say more than 8 centimeters or 9 centimeters. And if it's still not responsive, then I think something else ought to be considered. Of course, patient factors, all of those things come into play, but that's what we see in this study. And I see in the chat that there is a question that, are we pushing the envelope on EVAR? Historically, I think this center has been slow to adopt EVAR. And in this study group, it was a very few patients where the initial IFU was not met. So, and there were only 2 or 3, and only one of them which was, from the same institution. And again, I think this is a limitation of the study, because we don't have, we had papers from Dr. Mastracci, which sort of showed that, the neck does degenerate, but this study can't answer that question.
Another quick question, and again, this is almost like a double-edged sword, but clearly for patient factors, EVAR has less morbidity and less mortality that we expect, even though in your study for late aortic rupture, there was no difference ultimately between open repair and EVAR for late aortic rupture, which was important to note. But how do you, for those of you that are treating late aortic rupture, and we know that it's more common, probably because we're doing more EVAR after EVAR, to treat it with more endovascular means. So what would you be your surveillance criteria for those patients? What would you suggest for those of us treating patients with more endovascular means for a late aortic rupture after EVAR? What would you suggest we do? Since clearly the SVS criteria for 1, 3, 6, and 12 months, despite that, there is, we've seen at your one institution at 10% late aortic rupture. So do you think we need to change the surveillance criteria for that?
I think very overall, I think it has to be multi-institutional data and patient-specific data, which I think is, currently, at least in my mind, a limitation of how we study these patients. And I mean, I would open it to the house, like, we just don't have a good way of tracking and monitoring these patients, because they might have it done in one part of the country, leave, insurance, work. So there has to be a better way of monitoring these people. And I guess eventually we'll have better data, but for surveillance, I mean, in this study, most of the patients were the ones who were treated, were intervened on at appropriate surveillance intervals and by appropriate means, like coils, transcable or limb extensions, but still they grow. So, and like we said, it's rare. So I'm sure that, it's if a referral center is seeing only so few, out in the community, it's even lesser. And then those patients get lost.
Okay, thank you. I know there's a lot of questions in the chat.
Yeah,
Do you want me to read them out?
blowing up.
I think we have a few minutes to continue with going through these. So why don't we kind of try to answer each one of them if we can?
Okay, so for non-compliant type patients, should we lean more towards open surgery as the rupture rate will be higher? We open that up to the panel here. I know I can tell you in my practice, if the patients are non-compliant or I don't feel they're going to come back for appropriate surveillance schedules, we offer open reconstruction because we feel more comfortable and they won't end up at another hospital with an EVAR that wasn't surveilled appropriately with a late aortic rupture. I'm not sure if anybody else in the panel feels that way, but clearly we do at our facility.
I think that's what most people are still leaning towards for those types.
And for a controversial part that Dr. Calgary brought up, so are we saying or are we agreeing that lack of sac shrinkage, would that be an indication for repair? I know this comes up a lot in conversation. It's always controversial that the sac remains stable, but we really want to see sac shrinkage. So if you're not seeing sac shrinkage, how long do you wait before considering something more to be done, or you expect an occult endo leak? Just kind of opening it up to the panel here, if anybody has any specific algorithms.
Dr. Sen, did you see, what are your thoughts on that with your group?
Yeah, so we had a previous study which showed that there were 3 groups. There was one which shrank, they're fine. The ones who didn't shrink and the ones who grew. The ones who grew are obviously at the highest risk, aortic events and late mortality. So I think that group for sure, at least going forward in my practice, I'm going to sort of tell them that they need reintervention, maybe even an open repair. That's very clear. But then there are other, we've had those studies which say that a prone CT or other modes of imaging, how do we detect the ones, how do we better study the ones whose sacs aren't grown? I think that's open to the house, but for the ones where the sac is increasing and past scary enough size in an otherwise good risk patient who's still young enough and can tolerate an open repair, I think we should offer it early.
And I think Dr. Dahlman also made the comment, that there really aren't any recommendations if it's not shrinking that you can see through the European Society for Vascular Surgery.
Dr. Phillips?
Yeah, Nick and Misty, it's a great question because really what we want to know is the pressurization of the sac, right? And we're using sort of diameter as a surrogate for pressurization, and which it's not exactly sure like how tight that relationship is, and certainly other measurements have been used with pressurization in the past, like intrasac pressure measurement, volumetric analysis, and now more and more these days more complex mathematical models. And so I think we have to recognize, although, diameter measurement is the easiest thing to measure because we can do it very easily in the clinic, it's not a one-to-one relationship with respect to pressurization and then rupture risk.
Keith, is that your way of raising your hand? The old-fashioned way?
I admit it, I am not as technically savvy as Dr. Forbes with the yellow hand going up there, but I just wanted to point out, part of this discussion is, the close surveillance and how important that is. And we always felt that way too, but we published a study in JVS with kind of long-term follow-up of duplex surveillance. And we've, on the one hand, we found that if you didn't have long-term follow-up, if patients did not return, they were more likely to die. And everyone here is saying, well, yeah, that's what you guys just showed. But we found it wasn't due to rupture or even graft-related problems. The people who didn't come back for surveillance developed cancer or were sick or didn't want to drive the hour and a half because their mother had to be hospitalized, blah, blah. So what the conclusion of the paper was, yeah, you want to do the best you can, but I'm not sure we're going to be able to change that because there are other factors that affect follow-up. Thank you.
Well, I think that will help us segue into our next paper, where we're going to talk about the endovascular aneurysm repair offers a survival advantage and is cost effective over conservative management. So Dr. Shaw, you want to kick us off?
Sure, it's a pleasure. I'd like to thank you, Misty and Paul, for putting this all together, and thank the editors that are on the call tonight for all of your continued support of the journal and the tireless hours that you put in to make it great. So thank you for that.
Palma, I think you need to swap your slides too. So if you go back into there.
Yeah, Dina's going to do that. Dina has them all connected.
Okay.
She should try to. Is that better? Okay.
Yes, ma'am.
Okay, next slide. So EVAR has rapidly expanded as the preferred approach for treatment of AAA since its first report over 25 years ago. The current Society for Vascular Surgery guidelines recommend informing this cohort of patients of their vascular quality initiative perioperative mortality risk score for them to make a decision to proceed with an aneurysm repair. In the guidelines, you see table 4A in the center here, considers the treatment type, EVAR, open infrarenal, open suprarenal repair, aneurysm size, age, gender, etc., and assigns that a score. And then to the right, table 4B, assign points that are associated with the probability of mortality, putting patients into low, medium, high, or prohibitive risk categories. Next slide. The VSG&E tracks outcomes, including in-hospital mortality, adverse events, and long-term survival by matching patients with the Social Security Death Index. The primary outcome of interest was in-hospital post-procedural mortality in this study. And to create a risk predictive model of mortality, they included clinical variables of interest in a full predictive model using multivariable logistic regression. Backward elimination procedure is also used with an alpha equaling 0.2 to create a more parsimonious model of variables that independently predict mortality. The SVS guidelines suggest informing patients contemplating open repair or EVAR of their VQI perioperative mortality risk score. This VSG&E risk prediction model is best at forecasting mortality among this patient population. The DREAM trial's goal was to compare the quality of life in the first postoperative year after elective EVAR and open repair in a randomized study. Ultimately, they concluded that in the early postoperative period, there is a small yet significant quality of life advantage for EVAR compared to open repair. But at 6 months and beyond, those patients reported better quality of life after open repair than after EVAR. Next slide. The UK Endovascular Aneurysm Repair Trial, or EVAR-1, investigators have published their long-term results. This was one of the largest and admittedly most important prospective randomized trials comparing open and endovascular repair. The authors concluded that although EVAR had a 2.4 times lower perioperative mortality rate than open repair, there were no differences seen in total mortality or aneurysm-related mortality in the long term. But these authors you see here challenged this, Dr. Prodi, V. Starnes, and others, and they basically claimed that the EVAR-1 trial is misleading and casts an unfairly negative light on the superiority of EVAR, and conclude that EVAR is a better treatment for infrarenal aortic aneurysms in anatomically suitable patients. So the controversy goes on. The aim of EVAR-2 was to compare long-term total and aneurysm-related mortality in physically frail patients with abdominal aneurysms, randomized 400 patients at 33 centers. They concluded that EVAR does not increase the overall life expectancy in patients ineligible for open repair, but can reduce the aneurysm-related mortality. This meta-analysis of individual patient data from collective studies EVAR-1, DREAM, OVER, and ACE trials looked at outcomes of endovascular or open repair for abdominal aneurysms out to 5 years. This concluded that over 5 years, patients of marginal fitness had no early survival advantage from EVAR compared with open repair. Interestingly, some of these aforementioned trials included patient evaluations using a study called the cardiopulmonary exercise testing, or CPET, that provides an objective assessment of functional capacity. These authors assessed whether preoperative CPET identifies patients at risk of early death following elective open and endovascular AAA repair. The CPET values, which identify patients at increased risk of early death following AAA repair, include an anaerobic threshold below 10.2 mLs per kilogram per minute, a peak oxygen consumption less than 15 mLs per kilogram per minute, and at least 2 subthreshold. The National Institute for Health and Care Excellence, or the NICE clinical guidelines relating to the treatment of AAA were provided in 2020. They emphasize that EVAR is widely performed, but it's more expensive, and again, note that it produces no long-term benefit over open surgical repair in people with an unruptured infrarenal AAA. Next slide. The NICE clinical guideline relating to the treatment of AAA also suggests that EVAR for patients who are unfit for open surgical repair was not cost effective. NICE typically uses a threshold of US dollars 43,500 per quality or quality adjusted life year, gained to assess whether treatment is cost effective. The incremental cost effectiveness ratio, or the ICER, for EVAR in this population was estimated to be in US dollars almost $625,000 per quality gained. However, they also note that the major driver for this high figure was the use of a hazard ratio estimate that suggested that EVAR increased the risk of death after 4.5 years compared with untreated patients. So when there's no differential in deaths beyond 4.5 years, or when that's not assumed, the ICER drops down and the US dollar amount would be about 97,000. Thank you. I'll let Dina continue.
Thank you, Dr. Shaw, for the introduction. It was very thorough. My name is Dina Shahadi. I'm the first year fellow, not the second year at Upstate. I haven't gotten a promotion just yet. I just wanted to show a picture of our beautiful hospital and then talk about this paper. So the paper, the actual manuscript, Endovascular aneurysm repair offers a survival advantage and is cost effective compared with conservative management in patients physiologically unfit for open repair. So there's two objectives to this study. The primary objective was to compare overall and aneurysm-related survival in patients with poor CPET scores deemed unfit for open surgical repair based on CPET and a multidisciplinary review who underwent EVAR versus conservative therapy. The secondary objective was to compare the cost effectiveness between the two groups. This was a prospective database. This is a flow of the study, the methodology. So a prospective database of AAA patients referred for CPET was maintained from the years of 2005 to 2019. Data such as demographics, comorbid conditions, current medications, AAA size, CPET parameters, and survival were recorded. Retrospective analysis of this database and a review of hospital charts and imaging was performed to identify both short and long-term outcomes, endograft complications, and reinterventions and overall survival. All patients were discussed at a multidisciplinary panel, and that included an interventional radiologist, a vascular surgeon, and an anesthesiologist. As Dr. Shaw mentioned, anaerobic threshold, or what I'll refer to as AT, greater than 10.2 mils per kg per minute was the used cutoff value for fitness for open surgical repair, unless the technical or patient-related reason came into play. Patients who demonstrated an AT of less than 10.2 were offered EVAR or managed conservatively. There were contraindications to EVAR, such as anatomic factors that were taken into consideration, advanced dementia, advanced COPD, and a limited life expectancy. Patients who underwent fenestrated EVAR were excluded, and EVARs were performed by a team of interventional vascular radiologists with follow-up in a vascular radiology outpatient clinic with a CT scan at day 30, 6 months, and 1 year post-op. Conservative patients were managed on best medical therapy and were referred back to their PCP with no routine secondary follow-up, just a chart review and a census taken at 2020. So the demographics of the study, propensity matched analysis was performed to account for baseline differences between EVAR and the conservative management groups to minimize confounding. A propensity match score for each patient was calculated using multivariable logistic regression, in which treatment was performed, EVAR conservative was regressed on 4 baseline characteristics. So all the characteristics you see, they chose 4 to perform the propensity score matched analysis. And the 4 were age, sex, anaerobic threshold or AT, and aneurysm size. These were considered the highest potential confounding factors between groups and clearly affected the decision on treatment received and the outcome. A total of 350 patients were deemed suitable for EVAR, and that included AAA size of greater than 5.5 centimeters and an AT of less than 10.2, plus being unfit in general for open surgical repair. 135 underwent EVAR and 215 were managed conservatively. After propensity score matching, no difference, as you can see in the p-values highlighted there, was found in the 4 baseline characteristics of age, sex, anaerobic threshold, and aneurysm size. This is the propensity kernel density plots, just to show that before the scores, how far apart they are, and after propensity matched analysis was performed. And overall characteristics of perioperative outcomes. So 135 patients underwent EVAR. So 39% of the patients studied. Surgical cut down was performed in 20%, percutaneous in the majority, and then a combination in another 20%. They underwent a variety of anesthetic maneuvers, so general endotracheal, epidural, spinal, or local, and then they had different graphs, as you can see here. I do want to point out the supplementary table here. I have a blue arrow pointing to the amount of interventions. So it's 25 patients in total, or 17%, and all interventions were non-life-threatening. This is two plots showing the all-cause survival. The follow-up mean for this was about 9 years. 205 patients, or 59%, 39 in the EVAR group, and 106 in the conservative group had passed away. The median all-cause survival of both groups was 58 months, with EVAR being 84 months of survival and conservative group 30 months. The all-cause mortality at 30 and 90 days was lower in EVAR compared to conservative, with the 90-day mark being the significant value. The all-cause mortality rates, furthermore, in the 1, 3, and 5 year were also significantly lower in the EVAR group. Aneurysm-specific mortality was also looked at. 180 patients were reviewed, 97 in the EVAR group and 83 in the conservative group. Overall, 12 of the EVAR patients and 58 of the conservative patients passed away. They could not compare 100% survival, so they went at the 75th percentile, and EVAR versus conservative was 84 months versus 15, with a p-value of 0.001. Mortality related to the aneurysm at 30 and 90 days was also lower in the EVAR compared to conservative group, with 90 days being significant, and also the same in 1, 3, and 5 year follow-up. It was lower in the EVAR group. This is a forest plot showing the predictors of all-cause mortality. Notice I have highlighted frailty as the hazard ratio was 10. But in the univariate analysis, lower rate of vascular intervention, increasing age, lower BMI, higher frailty score were significant predictors of all-cause mortality. The stars are 1 star is univariate and 2 stars is multivariate. And if you were in the conservative group, you were 4 times more likely to die from any cause compared to EVAR. For aneurysm-specific mortality, this was the same, with the addition of RCRI index of above 3. And if you were in the conservative group, you were 8 times more likely to die from any cause compared to EVAR. So this is a base cost effectiveness sensitivity analysis. The mean cost of EVAR was found to be about, in this study, $19,000 in total, versus the NICE model showing that it's $20,000. The EVAR average benefit in 1.6 quality adjusted life years at an incremental cost, or ICER, of $18,000 compared to $11,000 in previous studies. This is found to be highly cost-effective compared with the $43,000 threshold mentioned in the paper from the previous study, quoted in the NICE model for cost effectiveness. So just some conclusions for the paper. The authors state that this is the largest study to their knowledge that demonstrates EVAR offers a survival advantage in patients unfit for open surgical repair compared to non-operative management. EVAR has a longer survival in the 1, 3, and 5 year periods over an overall surveillance of 12.5 years. And then in addition, in comparison to the EVAR2, it contradicts the conclusion that EVAR is not associated with the long overall survival, but it does agree with the EVAR2 paper in that aneurysm-related mortality is significantly reduced in the EVAR group compared with non-operative management. They do discuss their CPET versus the traffic light system versus the American ASA, and they do state that CPET is the gold standard for elective intra-abdominal procedures. They do point to other studies having a notable selection bias. which they tried to reduce by employing propensity match groups in the 4 variables that I discussed previously. They included a larger number of patients in total, including more unfit patients than previous studies, and they added an additional layer to their CPET with a patient-by-patient, case-by-case review by a multidisciplinary team. So these are the EVAR. I added this supplementary table to show the intervention rate for the EVAR2 study versus this study. EVAR2 stated concerns regarding reintervention rate. They quoted a 27% reintervention rate in the population that they studied. 50% of those, or half, were life-threatening, while 50% were serious. In the current study, 17% of the patients studied underwent reintervention over 12 years, and none were life-threatening. This is on par with more recent studies that quote a 9 to 17% reintervention rate. This reflects an overall evolving EVAR practice that is better improved with time. And they do mention that a secondary EVAR reintervention cost analysis should be included in future studies. They think that this study is a result of 2 things. So advancements in stent graft technology, increased durability, decreased intervention rates, adherence to IFU or indications for use. And then in operative hands, disease understanding is better, operative skill is better, and there's more instances of percutaneous access, allowing the patient to recover quicker. The ICER model showed $11,644 per QALY versus the $624,000 in the NICE model. The NICE NG 156 may not reflect contemporary EVAR practices. The drawbacks of the data that they used for reparametrization was not randomized. It did not completely remove bias despite the propensity score matching, because they only used 4 variables. And they give the example that the EVAR survival is similar to general population within the first 4.5 years. That way, sensitivity analysis assumes no survival benefit before or beyond 4.5 years. The conclusion is ICER is 18,000 per QALY gain versus the NICE star showed of 43,000. So they do demonstrate a cost effectiveness. So the limitation of this study, this is a retrospective analysis, and due to that, they lack exposure control, adequate reporting on multiple variables, and there is an introduction of selection and misclassification bias. Although they did propensity score matching to reduce selection bias, it's not completely eliminated. And the longevity, RCRI, and the Rockwood frailty score was not included. Additionally, reintervention cost was not included in this analysis. In conclusion, EVAR is associated with all-cause and aneurysm-related survival advantage versus no intervention in patients unfit for open surgical repair in the long term. In contrast to the 156 NICE analysis, EVAR has potential to be highly cost-effective with an estimated ICER of 11,000 per quality adjusted life year. And in the future, they recommend a randomized controlled trial to assess the efficacy of contemporary EVAR in patients unfit for open AAA repair, and a re-review of the NICE guidance in the NG 156 in light of the new trial results. Thank you.
Very nice. Dr. Harris, you want to kick us off for the discussion?
There was a great review of the paper there. Unfortunately, the authors can't be here, but they have indicated that they would take email questions. So I think there are a couple points that are really important, which is this does bring out that EVAR may be appropriate and may actually be cost effective in some patients that are unfit, but because it's not a randomized prospective study, kind of as you mentioned, we don't know that the group that was operated is really the same as the group that was not operated. And that has to do with frailty and some issues that you mentioned. So when you look at that, there were people who had a lower BMI, the neck was wider, a little bit shorter, fewer of them were on beta blockers or statins. There's some other differences. So likely there may have been a reason that that group didn't do as well. Having said that, the group that had EVAR still did very well. So I think the question is, where do we go from here? Should we be offering unfit patients more EVAR? Should we be doing prospective randomized trials? What are your thoughts? Dr. Shah, you want to take a stab at this one?
Sure. I'm not the author, but No, I think it's interesting how this article did point out, as you said, that the contrast between the NICE guidelines and the ICER amounts it's really dramatic, and it makes you at least question the NICE guidelines, and perhaps they may need some more modernization or a different reevaluation of their data. And I think that, at least in the United States, I'm not sure we could pull off the same exact trial, because I feel like patients come into our office, and frail or not frail, you'd have to make a really strong argument not to intervene on a lot of these patients and explain that to them and the family. At least I feel like that in my practice. So I think that I feel like I am offering EVAR more liberally to the frailer patients, unless they have a very short life expectancy. So I would agree with you.
Yeah, frailty is something that's still very difficult, and we haven't come up with the perfect methods to analyze that. And you're right, in the United States is a little different than some other countries. We do need to be cognizant of healthcare costs, though. And we all get healthcare report cards and all of that. The government is being more and more aware. So we do want to make sure that when we do procedures, that there is a benefit. So if someone is really deemed unfit, should we operate? And that becomes a question of how long is their life expectancy and what is their quality of life in that time period. Other questions or comments from the audience? Unfortunately, we don't have the authors to ask questions, but we can ask the panel here. We can ask some of the editors and editorial board members to comment as well.
Well, Ron made a comment about the NICE guidelines. Do you want to just give a brief?
Yeah, I don't want to, get too tangential about this, Palma, but, I wrote an editorial in the JVS about the NICE guidelines when they came out. I mean, they apply to the UK health system, which has all these fixed costs in the hospitals and the employees. They would never move to an outpatient or OBL-based approach to endografting because it doesn't make sense with the billions they have sunk into their health system the way it is. Plus, they insisted on only using prospective randomized trials for the data to support their recommendations, which, how many trials are that? EVAR, EVAR1, et cetera, which were already out of date by the time. So I don't know, this is exactly the kind of thing that we should be doing, which is using more recent data, trying to make it work as best as possible with propensity analysis to answer these really challenging questions. And I want to congratulate, Misty and Paul, the team, for selecting this manuscript, kind of very controversial topic. And I thought, Palma, you and Dr. Shihade did an excellent job of reviewing it. And, this is a great discussion. I really enjoy being part of this.
Actually, it was interesting because the dates included were 2005 to 2019. So even though we're saying this is more recent, the data might be even better for EVAR if we looked at 2010 or 2015. You look at all the changes that have occurred. So that's part of the problem is as we are measuring, the target keeps moving. And so it's hard to keep up with where we're really at. So there are a couple of comments in the chat. How are we to assess who should not be offered repair? I mean, that's a great question. I think, as Palma said, it's hard in this country to say no if you think someone has a reasonable life expectancy, and especially if it's something where you can get them through the procedures. Many of us now do EVARs with patients awake. You don't even have to put them under a general anesthetic. So if you can do a procedure without general anesthesia, if it can allay their fears, improve their quality of life, and they're going to be around for a few years, that's not necessarily a wrong thing to do. And I think what this showed is there is some financial benefit. There's reasonable quality of life, financial benefit to it. Let's see, second question. Not sure then an RCT of these patients would be practical or feasible. That is probably very true, unfortunately. I mean, it's always, we aspire to the randomized controlled trials. It's rare that we're going to actually get them. And even when you do, it's a matter of recruiting the right patients, because even when we get them, then we say they didn't recruit the right patients, or by the time we get the data, things have changed again. So, it's nice to have randomized controlled trials, but I'm not sure that's the answer to everything. Another comment, no patients were lost to follow-up, could have played a role in the outcome. It would have allowed for adequate surveillance and intervention when necessary. Is the demographic socioeconomic factors of the population study representative of the general population of patients presenting with AAA? That's hard to say. Obviously, they had really good follow-up. As we talked about in the previous paper, not all of our patients have the greatest follow-up. So that can obviously pose a problem there as well. I don't think you would still take an unfit patient and then offer them an open procedure. The question is, do you offer them anything? But that's another issue. Any other comments or questions? Can Tom Forbes comment from the Canadian perspective? That would be a great idea. Tom.
Yeah, well, I'm not sure it's very different. I mean, I agree with that. You know, an RCT is a great methodology, but I think we overstate its ability, or our ability to complete an RCT and its ability to really tell us what to do with every patient. So I don't think an RCT is the right methodology here. I mean, I can just say when I see a patient, it's probably very similar to when you do. You know, as long as it meets the diameter threshold and is posing a significant risk. And I think that the patient has at least about a 2-year life expectancy, then I discuss the prophylactic role of EVAR. It's, you know, how do you determine life expectancy? That's tough, right? There's the foot of the bed test, there's all the scorecards that we can use and everything else. That's tough, but we're trying to predict the future for an individual patient and then apply data and outcomes that have happened with other people. So it's an inexact science, but I don't think my experience is much different from anybody else on the call.
I guess one of the questions might be, should we have a different diameter threshold for people who are unfit for open surgery? So, you know, if a person's unfit, if they're not well, instead of 5.5 for a man, should we be looking at 6 centimeters? And for a woman, instead of 5, should we be looking at 5.5? I don't have the answer, just a thought-provoking comment. And I see Dr. Maloney has her hand raised.
Just kind of as an aside, not all EVARs or aneurysms are created equally. I think if you're looking at a very straightforward repair, good access, good neck, then it's a little easier to offer because you can tell the patient, you know, things are working in your favor. I can probably get you through this safely, even though, you know, your overall health is not at its best. Whereas if you're looking at fenestrations, you know, or neck, bad access, cut down, then it becomes a different conversation. So I think looking at those factors can help guide the conversation. And, you know, as is important with all patients, it's important to just have that conversation and let them know, these are the risks you're looking at. This is what we're looking at. I am worried about these things, and let them have
I think it's an excellent point, because the unfit patient, just like the very elderly patient, we can get them through if it's straightforward, but once there's a complication, it tends to snowball. And that's when, instead of extending their life, we may shorten their lives, which is not what we're trying to do. Any other comments or discussion? Oh, there's another comment here. 1 second. Let's see. Or different intervention threshold for active cigarette smokers or diabetics, other risk factors we know influence progression and rupture. Very nuanced areas, as all of us have emphasized in this discussion. Yep, good points. Any other comments?
Thank you, Dr. Harris. I mean, you handled that well, considering we didn't have the authors here, but I do think this is a good discussion. So we have had an hour worth of learning. We're very grateful to all the authors and our moderators, as well as our presenters. We will be back in March 9th at 7 p.m. Central Time. So please join us then and have a wonderful evening. Good night.
Thanks very much. Good night, everyone.
Right.
Thank you all.
Night.